Thank you to Monteris for having me for this webinar opportunity. I'm going to be talking about LITT for recurrent brain metastases today. All right, and so here's the mandatory disclaimer from Monteris. Here's my disclosure. All right, so in my practice, I mostly take care of patients with brain metastases. What we've all seen over the last decade is not only a significant increase in the number of patients treated with radiosurgery, but also an increase in the number of lesions treated per patient, which has resulted in an exponential increase in the total number of lesions being treated using radiosurgery per year. Concurrent with this growth of the use of radiosurgery has been an equally significant improvement in medical oncology options for cancer treatment. And this has resulted in significant lengthening of patient survival durations. And so over the past decade, I've learned two main things. The first, as you can see from this graph, is that in response to radiosurgery here at time 0, lesions have historically been shown to decrease in size and then remain stable in size for about 6 to 9 months. But in those patients who survive beyond the year, up to a third of treated lesions can be seen to regrow at some point, and this can affect as many as half of our radiosurgery treated patients over the course of their now extended lifetime. Secondly, what we now also know is that lesional regrowth can be due either to tumor regrowth or due to something called radiation necrosis, which is a post-radiation complication. Radiation necrosis has been described as a self-perpetuating, delayed inflammatory response to brain injury caused by high-dose radiation. But the pathophysiology behind this process is actually not really well understood. So if your lesion is regrowing after radiosurgery, what are the options for management? Well, ideally, management should depend on the pathology causing the regrowth. And so algorithms like this one are often used to decide next steps in management. So if you have brain tumor regrowth and systemic progression, then you could perhaps be treated with more radiation or a change in systemic therapy. If you have brain tumor regrowth and you have stable systemic disease, though, then you might consider open surgery for your regrowing lesion. If you have radiation necrosis, you could manage it medically, and so steroids being the most commonly used option, but many other options have been proposed. It is important to note that the only agent that has been shown to definitively work for radiation necrosis is bevacizumab, otherwise known as Avastin. Alternatively, if you had radiation necrosis, you could also have surgery. Differentiating regrowing tumor from radiation necrosis, however, remains a challenge radiographically today, despite a multitude of tests that have been studied over the past decade. You've all heard of using lesional morphology on T1-weighted gadolinium MRI, T1 to T2 comparisons, diffusion-weighted imaging, MR spectroscopy, MR perfusion, and PET. At the end of the day, though, none of these tests are perfect, and often patients are left with an unclear path forward. So to help decide what not to do next, there are a few things that I've learned over the years about management. And these are, firstly, that patients often dislike uncertainty. Second, that chronic steroids are morbid. Thirdly, that whole brain radiation therapy as salvage for a single regrowing lesion is becoming less and less popular given the potential cognitive side effects. Fourthly, bevacizumab is expensive. It has its own toxicity profile, and if you choose to use it empirically based on a presumption of radiation necrosis and you are wrong about the diagnosis, that it does not work alone for tumor. And lastly, repeat radiosurgery carries a 20% one-year risk of radiation necrosis, as shown in this extreme case of a 31-year-old female with triple positive breast cancer who was found to have 7 small brain metastases of this small size. And so by all intensive purposes, this patient should have lived a very long time. As part of standard of care for having more than 4 brain metastases, she received whole brain radiation therapy initially, and then underwent consolidated radiosurgery for all 7 lesions several months later. Later that year, as you can see, one of the treated lesions started to regrow. And so it became a little bit bigger again several months later. But given the deep location of the lesion, craniotomy for resection was felt to be too morbid for a patient with stage 4 cancer, and the patient underwent repeat hypofractionated radiation. Not only did the lesion not respond to this treatment, but 4 months later, you can see that the lesion had further increased in size, and workup including FDG PET and MR spectroscopy both suggested that this was tumor regrowing. So you can see that it was hot on PET and that the choline to NAA ratio on MR spectroscopy also was high. Because of progressive difficulty with speech and right hemiparesis, however, the patient was taken to the operating room for resection of this lesion, and the pathology was consistent with purely radiation necrosis with absolutely no evidence of tumor. Unfortunately, this patient never recovered functionally and went on to die in hospice. In comparison, what you can see from this study that we did at our institution quite a few years ago is that not only does craniotomy management allow for diagnosis of cause of lesional regrowth, but that particularly for patients with pure radiation necrosis, so this type 4 lesion, craniotomy can result in good local control and better patient survival. And so at our institution, we have been very aggressive surgically in the management of these patients. And so in the last case that we looked at, if only we had had a better surgical solution when the lesion was smaller, perhaps we may have been able to avert the terrible outcome. 2 further things then changed for me in my thinking about regrowing lesions after radiosurgery. The first was that just as radiosurgery is the big driver for the development of radiation necrosis, an equally important driver, we think, has been the use of CNS penetrating drugs such as immunotherapy and targeted therapies. While there is much conflicting data about the role of these drugs in the exacerbation of radiation necrosis, the use of immunotherapy often affects the patient's ability to use steroids. And this avoidance of steroids, in fact, is what drives the need to treat the regrowing lesion. The second is that many of my patients really don't want a craniotomy. And so this patient is an excellent representative of the kind of patient that we see a lot today. He was a 75-year-old gentleman with metastatic BRAF wild-type melanoma who underwent radiosurgery to 2 lesions, including this left occipital lesion here. The lesion responded nicely to radiosurgery, and then he got started on a drug called pembrolizumab, which is an immunotherapy agent. After his second dose of immunotherapy, he developed significant confusion, and on his MRI scan, you can see not only regrowth of the lesion, but significant edema around it, for which he had to stop his immunotherapy. Given his older age and persistent burden of systemic disease, however, his family were reluctant for him to undergo craniotomy. And so for me, this is where LITT has played a big role. So just as an aside, I wanted to walk you through my LITT workflow. I'm lucky enough to have an intraoperative MRI, and so we always get a preoperative scan with contrast in pins. I then use navigation based on the scan to drill a 3 mm twist drill hole through a 5 mm stab incision in the skin. I biopsy every lesion to obtain diagnosis, and then I place the laser along the path of the biopsy. We then drape for scan, and then with the scan, we go ahead and confirm positioning of the laser. Because I biopsy, there is often air or blood in the middle of the lesion, as you can see here. And so I always place the laser at the deepest point so that we can see its tip accurately to set up the scan planes for thermocoagulation. We then turn on the laser and monitor our heating. And so obviously this is a different patient than the one we described before. But I use the yellow lines, the yellow thermal lines, to make sure that the heat spread is safe. And then you can see me switching backwards and forwards to the blue TDT lines to check for completion of treatment. And so when complete, you can see that the blue thermal line encompasses the lesion, which means, however, that the yellow thermal line will extend beyond the lesion with a margin. And one of the things I like to do is to bring the post-ablation scan into our navigation system and compare it with the pre-ablation lesion. And I like to see this thin eggshell-like rim around the lesion at the end of the procedure. One of the concerns that many LITT users have expressed is the worry that LITT may make edema worse, especially if the yellow TDT lines extend beyond the lesion. While this has not been systematically studied, in my experience as demonstrated in this case, the edema at the end of my cases for radiation necrosis or regrowing tumor have not been significantly different than preoperatively. Obviously, what patients love about this procedure, though, is that the incision is small and many can go home the next day. I usually put them on a 5-day steroid taper, and many are back to their lives within the week. And so going back to our melanoma patient, his biopsy results were consistent with inflammatory changes and necrosis without evidence of tumor. And so even though the post-LITT lesion, demonstrated here again, is not significantly smaller than pre-op, you can see that there is already marked decrease in edema at 2 weeks, and then further decrease in the size of the lesion itself and the amount of edema over the next 3 months, despite going back on immunotherapy. And best of all, he only missed 1 dose of immunotherapy with this surgery, and so everyone was happy. While it remains unclear why LITT works for radiation necrosis, it is postulated that LITT inactivates the problematic inflammatory cells, thus altering the self-perpetuating process of the disease. LITT also works for regrowing tumor. This is a case of a 42-year-old female with known BRAF mutant metastatic melanoma, whose lesion responded to radiosurgery and then regrew again 12 months later. PET suggested that this regrowth was due to tumor, in my hands, the morbidity of surgically resecting this lesion is high. With LITT, however, we were able to completely ablate this lesion with a 2 parallel trajectory approach. So you can see the 2 trajectories actually quite nicely shown here. And at 2 weeks post-op, there is again that early decrease in edema, which again allowed for early tapering of steroids. At 3 months, it is interesting to note that the rate of resolution of the lesion was not equal all the way around. and there was some nodularity seen to one of the edges of the lesion. But given that there was no reappearance of edema, we continued to observe the lesion, and by 6 months, this lesion has shrunken down to its final size, and this lesion has now been stable for 5 years, and the patient continues to work full-time. So anecdotal cases are great, but how do we do as a group across different centers? Well, the largest prospective study looking at this population specifically was called the LASER study, and was published a few years ago now by Manmeet Ahluwalia, who's one of our colleagues in medical oncology. 6 centers participated in this study, and they recruited prospectively any adult patient with a brain metastasis lesion regrowing after radiosurgery that was felt to be amenable to LITT. And so this was user choice. The primary study endpoint was local control, and secondary endpoints were survival, safety, and cognitive and quality of life outcomes. Results from the study showed that 3-month survival across all patients was 86%, and 6-month survival was 72%, which is very reasonable in this patient population. Further, what became obvious is that just as we had seen with our earlier craniotomy data, patients with radiation necrosis did far better than those with regrowing tumor. And at 3 months, you can see that while there were no deaths in the radiation necrosis group, there was only a 70% survival in the tumor group. Further, individual local lesion control was excellent after LITT in patients with radiation necrosis. And this translated into good progression-free survival, particularly again when compared to those with regrowing tumor. For secondary outcomes, in those surviving 6 months, there was no notable decrease in the Karnofsky Performance Score, cognition, or quality of life measures, which in comparison with those, what we expect would be a progressive decline, this was considered a good outcome. And 70% of patients were no longer on steroids at last follow-up. The study, however, did report a 12% rate of complications and a 2.5% rate of 90-day readmissions. In retrospect, many of the complications were related to cases involving LITT in motor cortex or other related motor areas. And from these cases, many of us have learned a great deal about how to choose our LITT cases. Lastly, when the data was subdivided by ability of the surgeon to completely ablate versus subtotally ablate the lesion, as expected, total ablation of either radiation necrosis or tumor lesion can lead to complete resolution of the lesion. Subtotal ablation, also as expected, did not control tumor in the majority of cases. Interestingly, however, subtotal ablation of radiation necrosis lesions surprisingly resulted in stabilization of the lesion in most cases, although complete response was also not achieved. So this last finding has encouraged us to tackle regrowing lesions sooner, as you can see in this lung cancer patient. So this patient was being treated with immunotherapy, and as before, the lesions are now regrowing at 12 months after radiosurgery. Obviously, this lesion was not symptomatic, and so some might argue that it might never have needed therapy. But the increase in perilesional edema made the patient and medical oncologist anxious, and so rather than stopping immunotherapy and starting steroids, we just treated the lesion with upfront LITT. As you can see, after LITT, the lesion resolved, and the patient only ever received a single dose of steroid perioperatively and never missed a dose of immunotherapy. LITT use has grown significantly nationally over the past 5 years, and just as I have learned many lessons about using LITT and my practice has changed, so has it changed for many others around the country. To capture this real-life usage data, and outcomes, Monteris has an ongoing prospective multi-center registry called Lantern, where data from neuroablate procedures is being collected. There are now 24 active enrolling sites across the US that include a variety of institutions, and the registry is planned to enroll up to 1,000 patients. Over 600 cases have been enrolled to date, and from the registry, 3 manuscripts have been published. The most recent was in April of this year, published in Neurosurgery, looking specifically at the 12-month outcome data from the tumor cohort of the registry. In the metastasis subpopulation of 92 patients, it was seen that patients stayed just a little over a day in the hospital with very little ICU time. And the majority of patients were able to be discharged home as opposed to rehab or another institution. As you can see, complication rates have dropped significantly, and this is likely due to better patient selection, as well as us as surgeons being higher on the learning curve for how to choose LITT patients. There still remains an early survival advantage for radiation necrosis patients, although at 12 months, overall survival is about 70% for both groups, which is in fact comparable to radiosurgical outcomes in this patient population with known metastatic disease. So, given that the laser and the Lantern studies and our own practice have supported our belief that LITT is a safe and feasible treatment for this patient population, we then went back within our own institution to try and determine how LITT outcomes compared to craniotomy. And what we seemed to find was that craniotomy seemed to provide better symptom relief than LITT and better ability to wean off steroids. What we also noticed, however, was that these results were confounded by the fact that many of the lesions treated with craniotomy were larger, with the median volume of patients undergoing craniotomy being about 8 cc's compared to about 4 cc's for the LITT patient. And so when we went back and excluded all the lesions that were greater than 3 centimeters in diameter, what you can see now is that LITT appears to be equivalent to craniotomy, both in local lesional control as well as survival, and that outcome is now solely dependent upon the pathology of the disease. So based on all of these studies, which patients might actually benefit from LITT? So in addition to LITT being comparable to craniotomy for lesions less than 3 centimeters in diameter, as we just discussed, in my mind, there are several populations that seem to be best suited to LITT rather than craniotomy. The first population is the older patient, the patient that doesn't seem to do well with blood loss and has other medical comorbidities. Interestingly enough, they seem to do well with LITT. This is one of my many 80-year-old cancer survivors who adamantly refused craniotomy, but who was clearly anxious enough about his lesion to agree to LITT, from which he did well. LITT, I think, is also better for patients with deep lesions in whom craniotomy access could be morbid, such as this relatively small lesion in the cerebellar peduncle adjacent to the brainstem. With access through only a 5 millimeter stab incision in the suboccipital tissues and a 3 millimeter path through the cerebellum, this lesion was successfully lasered, and you can see resolved here, and all the risks of wound healing and suboccipital craniotomy were avoided. LITT has also been helpful in patients where craniotomy access to their lesions could result in noticeable loss of function, as in this 50-year-old male chauffeur. 11 months after radiosurgery, he had regrowth of this occipital lesion, causing headache, confusion, and homonymous hemianopsia. Craniotomy access to this lesion would for sure have knocked out these optic radiation fibers, But using LITT, we were able to choose an alternative access path and preserve his vision. Again, we see nice resolution of his lesion, and his vision actually recovered fully by 3 weeks after LITT, and he was able to return to driving as an occupation without any concerns. LITT can also be used to treat multiple lesions that can either occur simultaneously, as can be seen in these two cases, or more frequently, multiple lesions that occur over time. And so this example is an unfortunate 74-year-old lady with lung cancer who first had this posterior fossa lesion regrow, and then with resolution of that lesion, unfortunately, the left frontal lesion that was also treated with radiosurgery started to regrow too. And so gratefully, she had had a relatively good experience with her first LITT procedure, and so it was not too difficult for her to make the decision to have LITT again. Lastly, LITT can offer less conventional approaches to lesions, such as for this patient with a regrowing temporal lesion. The original craniotomy site was complicated by infection, and the bone had to be removed. Being able to approach this lesion from a virgin occipital approach allowed LITT treatment to take care of this radiation necrosis change. In addition, occasionally more unorthodox approaches, such as this one across the midline, can be entertained for more deeply located lesions. However, it is important to remember that LITT is not a decompression tool, and lesions larger than 3 centimeters in diameter may still benefit from craniotomy. This is another patient of mine who really didn't want a craniotomy despite significant symptomatology. We therefore tried LITT, but by 3 months later, you can see that his lesion was not better, his edema was not better, and his symptoms were clearly not better. And so he ultimately underwent open surgery with excellent resolution of all of the above. So given the growing popularity of LITT, both from the patient's as well as the surgeon's perspective, where does it fit then in the armamentarium of tools that we have for treatment of brain metastases? Well, the Congress of Neurosurgeons put out new guidelines for brain metastasis management in 2019. And in these guidelines, LITT is still listed under emerging treatments. But the guidelines do support a potential role for LITT for brain metastases regrowing after radiosurgical failure, particularly in the setting of radiation necrosis. It is important to note that the literature used for these guidelines cut off at December 2015. And so since then, there have been many more publications and now even multiple reviews on the use of LITT for these indications. I think, though, what is still needed are larger or multi-centered studies comparing craniotomy and best medical therapy for LITT, compared to LITT, to determine its actual role in this patient population. So where else can we go from here, though? Well, in the last few minutes, I'd like to share with you some initial additional experiences with LITT for post-radiation complications in benign lesions following radiosurgery. And so these are not brain metastases, obviously, but it's been a new direction in our work. So this is a 56-year-old female with NF2 who has had 4 craniotomies and 7 radiosurgery treatments for multiple meningiomas. The temporoparietal recurrence that you see in the top row was treated yet again with radiosurgery after the area had already been previously resected and consolidated with 54 gray or fractionated RT. Healing had been problematic from the original surgery. 6 months later, as you can see in the bottom row, she presented after radiosurgery with falls due to right hemiparesis, and her scans showed significant symptomatic edema around the lesion. Given the prior surgery, an alternative vertical approach to this lesion was chosen for LITT. And interestingly, there was a very gratifying response seen at 1 month follow-up. This patient is in fact now 7 years out from LITT and the region has remained completely stable since then. Similarly, this is a 45-year-old female who underwent radiosurgery to this right posterior temporal AVM. 18 months later, the lesion became a cystic-looking lesion with significant surrounding edema. Angiography at the time showed small residual AVM anterior and superior to this mass, which was embolized. And then a biopsy was performed that showed pathology consistent with radiation necrosis within the cystic region. 2 weeks following embolization, LITT was performed then via an occipital approach. And again, you can see the same gratifying edema resolution. And so in my practice, the role of LITT has become very well established for the treatment of brain metastases, both for recurring tumor as well as, but particularly for radiation necrosis. We still nationally need to do some work to reinforce this. But from the lessons we've learned from metastases patients, I believe that we can also find further applications for this minimally invasive tool. Before I end, I'd like to acknowledge my whole team at Yale, without whom none of this data would have been possible. Thank you for listening today, and I'd be happy to take any questions at this time.
Is it true that the first two cases presented were unlikely candidates for LITT due to proximity to the ventricle?
So, yeah, there's been a lot of discussion about fluid spaces and whether or not they somehow inhibit the conduction of heat through the tissues. So in my experience, the ventricles have not been as much of an issue. For me, they actually have been a safety net for kind of limiting where the heat goes and how much injury I can cause. I think the CSF spaces that have been more problematic for me actually have been sulci and vascular structures, even more of an issue than CSF spaces. So from my standpoint, being right next to the ventricle has not been a big issue. And in fact, we believe that with radiation necrosis, that the subependymal cells may in fact predispose people to developing radiation necrosis. So we have a fair amount of experience with burning right up against the ventricle.
What is the duration of these LITT cases from biopsy to education of the laser to closure?
So it depends a little bit on the lesion. So from the time of biopsy, it takes about probably 10 to 15 minutes for us to set up the laser itself. And then the part that takes a variable amount of time after that then is how long it takes to burn the lesion. So for radiation necrosis, it can be as short as 2 to 3 minutes. For a tumor, however, the time it takes can be longer. So with the NeuroBlate system, there are different size laser fibers and different power settings that can be used. And so if we know that this is tumor, then typically I will choose a larger fiber and a higher power setting. And with that, it can be probably 5 or 10 minutes of burning. So in total, as long as nothing breaks down, about 30 minutes should take you to completion. Okay.
Please discuss your opinion around the value of biopsy prior to LITT in the brain metastasis for the purpose of tumor marker reassessment for new targets, as we know that CNS Mets might have a different molecular profile.
So I completely 100% agree with that viewpoint. So there has been a lot of discussion about whether or not biopsy is a good thing for these lesions. And just to explain, the reason that surgeons prefer not to biopsy is because the introduction of air and blood can change the ability to see the thermographic changes on the MRI. And so at some point, there's a bit of a blind area around where the biopsy was done. And so if where the heat is going is critical, then sometimes it makes LITT more difficult. From an oncological standpoint, however, if this is a regrowing tumor, and particularly if it's regrowing in the setting of systemic stability, then one needs to be concerned that there are mutational or molecular differences between the brain metastasis and systemic metastases. And so Dr. Bastianos up in at the Mass General has put out a really nice paper a couple of years ago now that shows that brain metastases can actually differentiate relatively early in the mutational pathway, and so can be quite different than body metastases. And so if this is the case, and that is the reason for the brain metastasis failing, then it is important for us to understand this going forward.
Okay, there are some metastases that are more infiltrative to the surrounding brain. What margin out from the enhancing edge of a MET would you give for LITT? What margin would you give for glial tumors?
So for metastases, I think that the infiltrative edge is less of an issue. So if it is tumor regrowing, though, our practice has been that we don't believe that my ability to do LITT would necessarily result in complete ablation of the lesion. And so we have been following many of our LITT cases with hyperfractionated radiosurgery to make sure that we get good local control. So because of that, the margin around the lesion is perhaps less important, and much more important that the radiation that's delivered subsequently is larger field. For gliomas, however, my experience is a little bit more limited. We typically only offer to do smaller gliomas, mainly because of the infiltrative nature. And so in the cases that I've done, we've actually ablated beyond the T2 signal change to try and get best control.
And one last question, what specific issues have you experienced with LITT and blood vessels?
Gratefully, not too many. So with large blood vessels, as we had talked about before, vessels of the caliber like the MCA, for example, it will be difficult because those are heat sinks. It's difficult then to actually get the heating all the way to the vessel itself. So that's really mostly been the problem. With smaller vessels, it seems to be less of an issue. I've had one case where I've had an intraoperative hemorrhage. Hard to know if this was related to vessels in the area or whether it was just a hemorrhagic tumor to begin with. But there is a case report out there in the literature that talks about an aneurysmal change in the vessel after LITT. And so I guess that's always potentially possible. We have otherwise, from a venous standpoint, so big sinuses or big veins, those have not really been an issue for us at all. And we've actually lasered some cavernomas as well, and those have heated well without hemorrhage. So I think really the biggest issue for us is the large caliber vessels that just don't allow us to heat where we need to go. All right. Well, thanks everybody.
Yes, thank you so much for doing this, Dr. Chiang. We really appreciate your time and your expertise. And for everybody on, we will likely have additional webinars in the coming weeks, and we'll send out emails with the specifics of those once we have determined that. So thank you again, everyone, for joining, and enjoy the rest of your evening.